This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast, September 2025. How you doing, Ryan?
Spring is springing. It's beautiful down here.
Spring? Yeah, fall here. It's also beautiful. We got like 2 weeks of fall.
2 weeks of fall. Oh, did fall shut down? Straight to winter.
Yes. Fall's been furloughed.
Fall's been furloughed. Okay. Well, we'll just jump right into this month's issue. And the first article we're going to talk about is the spatial patterning of recent emergency medical treatment and Labor Act violations in the United States. Our lead author is Ariana Planey, and she is at the University of North Carolina. So first, a reminder, EMTALA, passed back in 1986 now, requires hospitals that take Medicare to provide an emergency medical screening exam to anyone who shows up. And we know this all too well, regardless of their ability to pay. And it prohibits patient dumping unless the patient requests a transfer or the hospital can't stabilize them. So what did these authors find on the topic? They found that between 2016 and 2022, there were nearly 3,900 EMTALA violations at more than 1,000 hospitals across all 50 states. The most commonly cited problems were not providing the required medical screening exam and violating quote-unquote anti-dumping rules by inappropriately transferring patients. Hospitals most likely to be in violation shared a few features. They were often for-profit, had gone through multiple ownership changes, and were part of larger health systems, and were so-called disproportionate share hospitals that serve high numbers of Medicaid and uninsured patients. Violations clustered in these so-called general acute care hospitals, especially mid-sized and large facilities. Psychiatric hospitals had fewer cases overall, but interestingly, a higher average number of violations per facility. When researchers mapped it out, they saw quote-unquote hotspots in the West, places like California and Oregon, as well as the Southeast, including Florida and the Carolinas, and then the Northeast around New York and Pennsylvania, which is sort of where the big hospitals are. These hotspots lined up specifically, though, with large health systems like the Healthcare Corporation of America, Advent Health, and Sutter, suggesting that some consolidation and centralized ownership may be playing a role. The takeaway, probably Medicare and Medicaid payment policies with EMTALA could help reduce the financial pressure to avoid quote-unquote unprofitable patients, but regulators may need to take hospital consolidation into account when weighing quality of care. So EMTALA violations aren't random. They cluster in specific regions in system-affiliated hospitals and institutions under financial pressure.
Yeah, I mean, all of that's not surprising, right? For-profit, bigger systems, so on and so forth. I guess it's just, there's not much what do we do with this information, right? It's hard to know, compare it with anything else. Is this happening more frequently, less frequently?
And the differences aren't huge either. So how much of this is related to the hospital and how much of it is related to the surrounding communities and behaviors and culture and other things that are unrelated to the leadership or the payment structures and those sorts of things. Although, once you get across all these different regions and you see the same behaviors happening at the same types of places, you do wonder if there is a sort of incentive that, an insidious incentive, as these authors suggest. And then, the solution is, do you change the policy? Do you tweak the policy? Do you crack down harder? We're basically already saying EMTALA is broken, because it basically forces hospitals to take in patients that there's nobody to pay for. And then the cost gets shifted and there's not a good mechanism to pay for it and to compensate these hospitals for that care. If there was, then you wouldn't have to worry about the cost shifting and eating the costs of uncompensated care. And then you'd have I don't know, maybe they'd be out there recruiting for these patients. I don't know. But the financial incentive, the problem is the financial incentives in our system that no other country has to deal with.
Well, I mean, that's the big thing, and I think that's what the authors are trying to get at. But it's confounded by, obviously, the methods of the study and the fact that, the big hospital systems are also the big hospitals, right? And so if this is a problem of financial incentives, or just a problem that, the larger hospital systems are burdened with these patients, and it's just more likely to occur in those areas.
And have you been at a hospital that's been cited for an EMTALA violation? And have you been part of the group that's had to deal with it?
I have not been part of the group. I have no idea.
Oh, okay. I mean, I've been at hospitals, busy hospitals that have been cited for EMTALA, and it's usually the ones I've been associated with are the failure to provide a medical screening examination, and it's because it's just so freaking busy. It's they were there, but we didn't get to them. or they left, they sat in the lobby and they waited, but they registered but didn't actually get screened because it was just overwhelmingly busy. So, I mean, there is some aspect of that could be contributing, and you just don't know. This data doesn't go granular, doesn't have that kind of granular picture of why these patients are failing their medical screening examinations, because 3,900 different violations to investigate. They couldn't do it.
Right. And so it doesn't really give us a straight answer or gives us any kind of guidance on how we use this to fix it.
The bird's eye, the 1,000-mile view, the satellite view of EMTALA violations.
Yeah. We need to zoom in a little bit. Well, let's move on. The next article is short stay hospitalizations and hospital capacity constraints. And the lead author is Alexander Janke. So this is an attempt to look at the causes of ED boarding and try to look at some ways or attempts that maybe we can change some of the capacity restraints that we currently have to improve ED boarding. Essentially, this was a retrospective cross-sectional study over 4 large academic centers from 2018 to 2024. And the authors looked at over 2 million visits, which included over 600,000 hospitalizations. And they are essentially trying to look at short stay visits and see how much short stay visits were responsible for the capacitance problems in the HIT system and then ED boarding. So total occupancy hours were calculated by subtracting hospital departure from ED disposition. And obviously the difference between those is the stay in the hospital. And then they defined short stays as hospital stays less than 48 hours. And they included observation stays in that. And then they wanted to look at how much these short stays contributed to hospital occupancy and compare them with ED boarding times. Overall, what they found was about 33% of the hospitalizations were short stay hospitalizations. But the impact on capacity was far less than that. Only 7.6% of the total occupancy hours were taken up by these short stay hospitalizations, obviously, because the longer stay ones are just there much longer. What they found over time, they showed that short stays decreased slightly over the course of the study, but ED boarding time increased. When they looked at it, they did kind of a retrospective chart review, and they felt like 10% of these short stays were potentially avoidable admissions altogether, including some things like low-risk chest pain, syncope, sepsis, or cellulitis, so on and so forth. All in all, obviously, this is fairly limited. It's a retrospective cross-sectional study. It's only done at a few academic centers. It's unclear whether this is generalizable to the rest of our hospital system. It's also a chart review. But I think one thing's fairly clear, that ED boarding is a complex problem that really has to do with hospital capacity, inflow, outflow, so on and so forth. And there's probably no one thing we're going to be able to do to fix it. Kind of these quick fix answers are probably not going to be the solution.
No, Rory, ED boarding is the ED's fault, and it's the ED's problem to fix.
We're all too lazy.
We're just admitting too many patients who don't need to be admitted. I mean, this is like this is something that gets reflected to us from a hospital administration all the time. That like, oh, if only you guys were better at like discerning the medical emergencies from the patients who could get sent home, or you could turn these people around better. I think there's a lot of perception up in what they would call like the C-suite, potentially, of avoidable issues that the ED contributes to inpatient, and that this is one of those attempts to combat that perception. And it's probably it's a fair look. I mean, I don't think that there's that many 48-hour or less hospitalizations that can be legitimately avoided. I think emergency doctors are pretty good at figuring out who is safe to go home. The low risk chest pains, the low risk syncopes. Yeah, maybe there's always people and situations that could be better, but we also don't know the granular stuff behind that chart review. It's a low risk syncope on paper, but it's also somebody who's not safe at home and doesn't have supports, and they turned their water and heat got turned off yesterday. So you don't have any idea exactly from these chart reviews exactly which ones are truly unnecessary. I think even doing that sort of analysis may have been, I don't know, playing into their hands a little bit.
Yeah, I mean, I think the other thing is like, this is not the only study in this data set, right? Like we have lots of data showing it's the throughput problems that really create the capacity issues, the inability to get people in and out of the hospital over a reasonable amount of time. But even that, it's so multifactorial. There's so many reasons why there's ED boarding, but ED boarding is clearly the symptom of this broken system.
Yeah, for sure. And it's not our fault. All right. The next article we'll talk about in this issue is called Effect of Routine Opt-out HIV Screening on Emergency Department Operational Metrics. Results from the Pragmatic Randomized HIV Tested Trial. Our lead author here is Austin Jones, and they're at the Denver Health Medical Center. So we're back in HIV tested land again, which has been discussed previously regarding yield and cost effectiveness. And this time we're talking about the other obvious question. Can we really use the ED as our catch-all screening destination without otherwise impacting its primary mission of medication refills and 3 a.m. dental pain? If you recall, there were 3 different arms in this HIV tested trial: non-targeted screening, enhanced targeted screening, and traditional targeted screening. Data was gathered from outside the screening period to use as a control for each site in an attempt to determine the effect of, if any, of the screening process on ED operations. There were about 125,000 total patients in the intervention periods, with 65,000 randomized into the various screening strategies. And of the randomized, about 60% were offered HIV screening, with 13,000 tests completed. These were compared with approximately 250,000 visits from outside the screening periods. Using many adjustments, the authors observed a 1.4 minute increase in wait times for those included in HIV screening, reductions in ED length of stay for admitted patients, no change for non-admitted patients, and a 10% increase in left without being seen rates. The authors conclude HIV screening is justified based on their inability to detect reliable or clinically meaningful effect sizes for the impact of screening on ED operations. I just fundamentally disagree with their conclusion and approach. The basic question is, does HIV screening take 0 time? In the non-targeted group, there's a simple opt-out question during medical screening. Reasonably, this only adds a few seconds. However, the enhanced targeted and traditional targeted groups underwent the Denver HIV Risk Score questionnaire or the behavioral risk screening tool, which take measurable amounts of additional time. In fact, this measurable additional time is knowable and observable. To correctly assess the effect of these screening methods on total triage time, it would be very trivial and reasonable to directly observe the triage process and time, how long it takes to ask the questions associated with the screening process. These authors have taken a 1,000 miles away viewpoint full of confounding features and imprecision when they could easily quantify the 10 seconds, 40 seconds, extra minute, who knows, amount of time per patient. And then you can multiply that by the hundreds of patients triaged a day, and you can quantify how many person minutes or hours are being devoted to screening at triage. Then, if there's additional time being spent for blood draws outside of routine operations, this is, again, directly measurable and observable as a further impact. Rather than just looking for the ripples of these operational events in muddy waters, the authors should just directly measure the events. In fact, I'd go so far to say, if these authors don't see any differences, they ought to be concerned that in this zero-sum nature of a saturated emergency department, it means something else is being neglected for this screening, and wonder what that might be.
So that last point is that's the key right there, right? We talk about this all the time. It's a zero-sum game, and we are inundated with new screening tests. Every month, there's some other suggested screening test that we should do in the emergency department that is only peripherally related to emergency medicine. And we can do them all, and they all might individually take only a small amount of time. But when you add them up, something else is not going to be done. And we just talked about how our system is broken and overburdened and crashing and not working. And yet all we decide to do to fix it is add more documentation burden, more screening burden, more everything else to the emergency department, which is clearly already overburdened.
Because the gist is these authors are trying to argue that there's no impact on ED operations from this screening thing, but it takes a real amount of time. There's no way around it. Maybe it's 20 seconds, maybe it's a minute, maybe it's not. But 20 seconds times 400 patients walking in a day adds up to real person minutes, and those are person minutes. They can't be doing another ED related activity. So if everything's flowing smoothly, that means something else is getting dropped. So it actually doesn't. There's no face validity to the fact that this doesn't add extra time to it, unless you should start worrying about what they're not using or not spending time on if they're spending time on this screening procedure,
right? Or the patients,
or they're spending extra money for extra staff, like et cetera, et cetera. It's not free.
Yeah, and it's not to say this isn't valuable, but I think you need to put it in the context of everything else and decide what is valuable, what's not, with the understanding that we can't do everything.
We can't do everything for free. Yeah, if you want to do more things in the emergency department, you need to put more people and staff in the emergency department. If you don't want it, otherwise there's no free lunch. You're going to end up getting longer wait times, or you're going to start dropping something else.
Our next article is Formative Evaluation to Inform Implementation of Sepsis Bundles in Emergency Departments. And the lead author is Hannah Frank. So straight off, I'm not sure I agree with their initial sentence, which is sepsis bundles are effective in reducing mortality and sepsis.
No, their leading sentence is sepsis is the leading cause of admissions to intensive care units.
Yeah.
Abstract versus the background. Yeah.
Yeah. So, I mean, if we can step by that right now, because I think data set after data set has shown that's not the case, that sepsis bundles don't really do much. There's some individual components of the bundles which are very important, others that aren't important at all. But
and certain patients in which they are important, other patients in which they're not.
But take that aside. How do we implement these bundles? Because the government says we have to do it in a certain amount of time. And so if we want to make our metrics look good, what are the roadblocks that are inhibiting us from these metrics? What are the things that are helping us? These authors wanted to figure out what roadblocks were inhibiting the completion of these sepsis bundles and how they and the things they might do to improve performance metrics. So they conducted a formative evaluation guided by the EPIS framework, which is exploration, preparation, implementation, and sustainment, which is essentially they conducted a number of qualitative interviews and quantitative surveys across 18 emergency departments in the U.S. These included both academic and community hospitals, and participants included nurses, physicians, and pharmacists. And the aim was essentially to identify these barriers and facilitators to a successful bundle completion. The cohort was mostly made up of nurses and RNs. About 46% were MDs, 45% were nurses. The rest were pharmacists, physician's assistants, nurse practitioners, so on and so forth. And they identified a number of things, and they kind of defined these. First were outer contexts, which are patient characteristics, and basically identified that geriatric populations, patients with complex health issues, were especially challenging to assess, to diagnose, to treat for sepsis, and all these things led to delays in completion of the bundle. And then there was kind of more logistic problems that again got worse with more complex patients, such as difficulties with intravenous access in patients that had difficult access, resulting in days in blood cultures, antibiotic administration, fluid administration, all these things as the patients get more complicated, leading to delays in the completion of the bundle. The next category they defined as inner context or organizational characteristics. And these included challenges of coordinating with other departments, miscommunication. The rapid team finds a patient on the floor. They then have to go talk to the hospitalist. They have to find the hospitalist who's taking care of the patient, have them put in orders. They then have to get an ICU triage. Then a triage assessment has to be done. All this delays care for a patient. Next were bridging factors. These were basically organizational factors. So what they define as like staffing shortages, nursing shortages, ED boarding, all these things again inhibit good care and inhibit the completion of these bundles. And the final thing was innovation factors. And these are kind of questions about the actual how we treat sepsis appropriately. So, most of these sepsis bundles recommend giving a certain amount of fluid. There's obviously a lot of educated clinicians that understand that sepsis is a vasodilatory shock. Not all these patients need fluid, especially if they've been sitting in the hospital for 5 days and have been resuscitated and hydrated, and giving them more fluid might be more harmful than helpful. There's obviously concerns about antibiotics and overprescribing antibiotics and leading to resistance, so on and so forth. And so the idea is how do we best take all this stuff and come up with a bundle that can be completed quickly? The first thing is nurse-driven protocols, right? Empowering, essentially allowing the nurses when a sepsis alert fires to drive the protocol without having to go to the clinicians, without having to talk to the consultants. So all the stuff can be done pretty streamlined without 16 different phone calls. Clear and straightforward bundles, and then obviously strong leadership and sepsis champions to promote stuff through the system. So I mean, I think we've talked about this a lot. I am not a fan of these bundles. Again, like we said earlier, I don't think this is going to save our septic patients. I think the other idea is sepsis is the final common pathway in almost all diseases, right? Most patients that die from sepsis because they're dying from something else. And so trying to differentiate patients that are dying from patients who have a salvageable and modifiable disease state are super important as well. And then focusing rather on these bundles, focusing on things that matter. It's getting like educated clinicians to the bedside, caring for these patients without any mandated amount of fluid, antibiotics, lactates, so on and so forth. It's just getting eyes on the patient, I think, is probably the most important thing you can do.
Well, I mean, this is an article that's not for doctors. I mean, you and I know that the most important thing is getting eyes on the patient and gathering information and making a treatment plan that's personalized to that patient. This article is for operational people who are trying to look at the barriers and trying to implement as they are told to by their higher ups, these sepsis bundles, and why are they having fallouts and why are they having delays? And this is, goes through the context and the barriers and those sorts of things. And so it's a framework for people to look at their own sepsis, bundles or other bundles throughout the hospital and see, where are we coming up short and what might be and how can I use this framework to evaluate the barriers and then address those barriers. And some, it talks about this in the innovation factors section. It basically says lack of flexibility in bundle elements may not align with patient needs. And those that you just talked about that's from a physician or a clinician standpoint. That's the huge barrier to implementing some of these bundles sometimes, is that we just don't think they're appropriate as a blanket implementation for our patients. And you could say, well, maybe there's a way to facilitate that by making it really easy for clinicians to put in the documentation necessary to make them not be a fallout when they're providing the care that's correct for the patient. Because I think that's really what gets us. We do the right thing, the patient gets better, or we feel like we've actually done the right thing for the patient, regardless of whether they get better. That's actually sometimes impossible to control. But then you get an email, a week later saying that you didn't tag specific elements in you can go back and revise your documentation. And you're just like, this is all about barriers and facilitation and implementation of bundles and pathways. And it's totally separate from the clinical side of medicine.
Yeah, but like the point that gets me is the gaslighting. It's like the idea that this is once we do this, we're going to save lives. Because I think you're right? Like I think the way to do this right, and it's not the way it's done now. The way it's done now is how do we game the system and like make it seem like we've done, completed these bundles as best we can, or how do we like take the patient out of the analysis by putting them on hospice comfort, which may be appropriate to do, but it's all a numbers game. The question is, how do we align these bundles with good care? And I think what you're saying is probably the most important. It's creating bundles that have like some versatility and laxity in them to kind of allow clinicians to do the care that they want or that they feel is necessary for the patients. But I think the bigger thing is like, how do we get like actual adults educated and like clinicians to the bedsides, to the patients that need them, right? Without overwhelming the system, right? Because again, most of these things is we have to identify every patient who might possibly have any amount of chance of having sepsis. And, if the alarm goes off all the time, no one's listening anymore. And so it's an effective way of identifying the patients who are truly at risk of bad outcomes in a time-dependent manner.
Yeah, I mean, to some extent, but when you look at this article, you also look at saying, well, all the incentives are in place to do the wrong thing. So how can we build a system where it actually doesn't disincentivize people who want to do the right thing? And there's like this quote here. It's like, when the physicians don't use the order set, we have fallout in the amount of fluid someone has gotten. Well, wouldn't it be great if somebody made an order for fluid that was less than the amount of fluid prescribed, automatically just slipped something in their documentation saying clinical evaluation, based on clinical evaluation of this patient, it was deemed that this patient should not require the sepsis guideline mandated fluids, and for X reason. There's ways to help people do the right thing, but medicine is usually not set up that way.
Right. I think, when you get to the innovation part of this is what needs to happen here, right? Like this is AI, this is the role for AI. And we don't have an AI article this month, so we might as well talk about it now, right?
Which is true. really good at doing things doing things quote unquote right, because it doesn't have there's nobody breathing down its neck and a fire it kind of thing, or it doesn't have a patient satisfaction score to fill out, kind of thing on it. It's a robot. You have these simulated case things where it's supposed to do prescribing for upper respiratory illness, and it's just doctors give out azithromycin and steroids for everybody with a cough. The AI is no, the guidelines say, and you can't argue with it. It's just a computer.
I mean, I argue with ChatGPT all the time. You can argue with it.
You can.
But I think the point is that using AI not to tell us what to do medically, but using AI to document the things we did, which was good care, and make it fit the sepsis pathways, right?
Sure.
Because most of the stuff can be documented away. And our problem usually isn't in the care, it's in the documentation of why the care wasn't followed.
Yes.
Right.
It could infer from the electronic health record and the problem list why this patient did not get the fluid, the maximum fluid bolus that it potentially could have had, and it could help you make the correct documentation so that you meet the bundle criteria or can be appropriately excluded. There's ways to do that. But again, this is just so much extra burden and cost. This is why American healthcare is so expensive, because we're talking about using AI to, an expensive AI and data science to fix a problem that's just fundamentally, that we've made for ourselves.
Right. Yeah, but how many committees, how many meetings are on this already? Right, this is something that takes a lot of time and energy because it's a quality metric.
Oh, I'm well aware. I haven't had to deal with a sepsis alert in over 5 years, and I love it.
Yeah. But and no matter what we have to do, we have to get rid of the time negative lactate. You have to draw lactate before the patient even arrives in the hospital. It's just
before the sepsis. Yes.
Before the sepsis, everything should already be done, right?
Well, that's Minority Report, pre-crime, pre-sepsis.
And the other thing that I think people have to understand is 3 hours seems like a long time. It's a second in hospital timelines, right? That takes to get anything done in 3 hours is incredibly hard because of all the logistical roadblocks that occur in the hospital.
Because of the HIV screening questionnaire you had to complete.
Exactly.
All right.
Yes, but it's true, right? Because everyone is doing a million things at once. And everything is a priority.
Everything is important. Well, on that cheerful note, we'll be back next month with lots more good news, I'm sure.
As always, with any questions, comments, or concerns, we can be reached at annalsaudio@acep.org. Until next time, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.